oxygen levels may diminish a little as we will talk a lot, but we'll do our level best. And we do have an exceptionally busy agenda today, which is delightfully bookended by two items to do with children and young people. One led by Bernie and Dickon, which is about existing services, and then Isabel and Tamsin will be joining us to talk about Cambridge Children's Hospital, which that's towards the end. Excuse me. So quite rightly, good to have a focus on our current and future services for children and young people. And good morning to you, Raj. Good morning, Rick. Lovely to have you with us.
Good morning.
So we're just going to.
Are you able to hear me?
Yes, we can, Bernie. Yeah, absolutely fine.
Thank you.
So I'm going to invite Bernie and Dickon to talk to us about the wonderful work that they do, the highly impactful work that they do with young people. So over to you.
Thank you. My name is Dickon Bevington. I'm a child and adolescent psychiatrist, and I've worked with the CASES team since it was first founded. It's one of the honours and joys of my life to work with Bernie. If I might occasionally wiggle a stick, she is the virtuoso player. So Bernie, you're going to keep me to reality
Yes.
and chip in where possible, but we recognise we don't have a great deal of time. So I'm going to just tell you the story of, this is a fully anonymised case. It's really a composite of a number of cases, but we really have tried to keep it true to life. And the team works from, if you like, at the mildest end to very severe needs. And this, we've deliberately chosen a young person who's not at the most severe end, but who is probably one of the more realistic stories. So we're going to call this young person Fergus. If you could just go on to the next slide. So Fergus was referred during a crisis as a 15-year-old boy from a white British background. And not atypical for this team. He was using multiple different substances, particularly MDMA, also known as ecstasy, using that at least daily and really getting himself into some risks of exploitation and everything else. He was a heavy, more than regular daily cannabis user, and had just begun using occasional and increasing amounts of ketamine, which is a substance we're seeing more and more with young people at the moment. Coupled with that, what emerged more over the first few weeks, he was having quite intense and frequent suicidal ideation, and he had a very significant trauma history, which again tumbled out a little bit over the first few weeks of our contact. He'd been violently assaulted by multiple other young people in the context of school bullying and conflict. And the precipitating crisis was that he had managed to obtain from a family member some oral morphine, and had decided that this was an additional substance that he might want to try. So whether or not it was a truly suicidal act, we were not ever completely convinced. But he ended up in ER, emergency department, with an overdose. So things were pretty difficult. But one of the things that our team always wants to look for is, well, where are the resiliences? And this actually was a young person who, was extremely academically gifted. And it is not always the case with the young people we work with in this team. He had two very well engaged and supportive parents, although for understandable reasons, very anxious about what was going on. We could just whiz on. So the team really works with young people where they feel safe to be seen and where they feel they're most likely to talk. So whether that's at home, in school, at a different place. I've done assessments in McDonald's before. So we will meet young people according to a risk assessment where they feel they're most likely to have a meaningful conversation with us. We started meeting him weekly, went down to sort of fortnightly after a little while. And one of the key things of our team is to create a relationship of trust. That particularly young people using substances, very often they've decided that they're their own doctor, they're treating their distress, and they have often very low confidence or trust in experts, particularly grey-haired old men like me. And we work really hard to build that. And we use an approach called AMBIT, which I can just boast was started in CPFT in this very team about 20-something years ago, and is now in use with about 200 or 300 teams all around the world, from America to Australia and across large bits of Europe. So AMBIT is an approach that I'm not going to explain in detail, but one of the things we take a lot of attention to is that we push workers into relationships with young people in risky situations, and they need a team around them to feel that they're working individually but never alone. We do a lot of work to scaffold the relationships around a young person, but never to forget that some of those relationships are, in the vernacular, dodgy, so that we have to manage the risks. And that's a kind of two different modes of thinking, really, that need to be held in balance. And we're always interested in getting back into sort of linking them into life, because the most potent way to help a young person out of substance use is to have something better and more interesting and more stimulating and rewarding to do. So we build up engagement. We use the phrase epistemic trust. That's this belief in a young person, not just that I'm clever, but that whatever knowledge is in my mind might be actually relevant in their context and in their world. And that's a big ask for many of these young people. So we do these rich kind of multi-domain assessments. We're not just asking about drugs. We really need to know about all of them. And we do a lot of rich measurements about that. In this case, we want to do some immediate safety planning, start a bit of psychoeducation, get a sense of whether this young person knew anything about the drugs that he was using or not, and obviously to start particularly with cannabis, because that was the one that he was most frequently using. Can we move on? Many of the young people, and this young person, really had kind of parents and school involved, but actually his network was much smaller than many of the young people who have youth justice, social services, housing, educational inclusion services, etc., etc. So we do a lot of work to try to make sure that we take all the minds around this young person actually as seriously as Fergus is in this case. We use this mentalizing and motivational work to help a young person to start to explore the kind of why. Why am I doing this? On what level of is it working, and do we take that seriously? And what level of it is it definitely harming and damaging? To help really empower them to make decisions about their future. In this case, we did some much more specific PTSD, post-traumatic stress disorder work. We have within the team resources to do EMDR therapy for that, and a lot of work on the substance use, obviously. But I suppose I really want to emphasize the fact that this team doesn't just sit and talk about drugs with young people, because although that's interesting, actually it gets very boring. And the really interesting thing is the context that you're trying to really reintegrate this young person into. So liaising with the school, helping the school to avoid what is often the case, that they would exclude a young person, and to really support them to kind of help this young person to reintegrate. Part of the thing, if we could just go on to the next slide, that we did recognise that after a few weeks we weren't getting as far or as fast as we had hoped. Parents were incredibly anxious, and I think felt, what's going on? You're meant to be sort of solving this problem. So in that relationship, the young person was brought to see me, and I definitely diagnosed very clear, quite significant depression and anxiety along with this trauma symptoms. And also a kind of which is a very common occurrence, unfortunately, a long history of undiagnosed ADHD. Because this young person was extremely bright, he could sort of mask and manage. But actually, you know, one of the most common causes or agents that sort of drive substance use is untreated ADHD. So we were able to kind of do a bit of liaison with our local ADHD services and agree that we could manage the assessment for the ADHD and even the titration of medication within our team, rather than having to send him off to other people, and then we could liaise so that his follow-up would happen that way. And that happened. So if we could just pass on, and then I think we're coming towards the end. Next slide. Yeah, thanks. So actually, we developed an incredibly strong relationship with Fergus. That's not unusual in his team. We did a lot of work with the parents to help the parents manage their anxiety so that their anxiety didn't then kind of actually inflame the relationship. We worked with Fergus for just under 2 years, which is on the longer side, but I think felt that there was constant movement towards more positive impacts. ADHD medication was hugely helpful. He got back into college, and college became more important to him than his drug use, which is, as I said, a common trick if we can make it work. And re-engaged with his social world, because he'd really withdrawn because of the trauma and his sense that the social world was unsafe. So by the time he was discharged, he hadn't been using any Class A drugs. He hadn't been using ketamine. He was using cannabis just very occasionally and only in company. And that's one of the differentials between very problematic use, which tends to be alone, where you just want to save your drug for yourself. He was using it, you know, occasionally in a party, which not ideal, but relative to where he was when we met him, we felt very pleased about that. And you know, he was in the middle of applying for a very prestigious university to study science. And whether or not this is a marker of success, he wanted to follow a career into mental health. So I think there's just one last slide. I suppose what I wanted to kind of point out is active family engagement and participation is probably for us one of the strongest predictors of success. And obviously for many of the young people we work with, that's not an option. But in our team, we have to kind of show what I would call a kind of cultural humility, that we have to recognize that we don't know the young person as well as the parents do, and we certainly don't know their context. But being able to kind of say when we acknowledge where we've not quite got hold of it in a way that the parents can believe is really helpful. And to be able to speak about our kind of learning in real time with parents and young people is one of our kind of, I think, superpowers. And I say that because that's how the team work, really, isn't it?
Yes.
I mentioned relationship building, so I won't go on to that. And this really sort of dogged and persistent attention to paying as much attention to the professional networks and the different professionals and what they need and what they're anxious about, as we do to thinking about the needs of our individual patient. And I suppose we have a sort of saying that, you know, it's very tempting to think that we've put a package of help together. But actually, as a clinician, you only ever join a helping network. It may be a helping network that includes drug dealers at the beginning, and I don't think they're very helpful. But in the mind of a young person, they often say to me, that's the most helpful person in my life. So I have to have a humility to just sort of say, I'm only one of a range of helping options, and then work to demonstrate that we can create more helpful networks. And there's one final thing that a few years back, if you pass on to the next slide, we published a paper which we're just doing a large tranche of outcomes data to do a sort of follow-up with this. But what this paper demonstrated was that it was the improvements across the sort of range of life function that mapped most closely to improvements in substance use, and that substance use, treating it alone is just never really an option unless you're dealing with their mental health, their social life, their educational life. And that's been the privilege for me, and I think Bernie, you too, to work with a team that really get this stuff. Bernie, I've probably left
Absolutely.
out lots. Is there anything you want to just add?
Well, I mean, it's a whistle-stop tour. We've already gone over time, unfortunately. I think one of the key things that I'd like to say in context of the manager of the service, we're a small team. We cover a very large geographical area, and one of our sort of something that we're very proud of is our ability to respond very quickly to young people seeking help. So our tagline would be that nothing should be a barrier to a young person seeking help. So we aim and we manage to respond very, very quickly, usually within days, sometimes sooner if there's particular substances that we're particularly worried about in terms of immediate risk and harm. But obviously, in terms of motivation for the young person, the minute they're murmuring that they want help is when we try to zoom in, because their motivation for help changes very quickly. So we're a little bit we're very, very responsive. It's a fabulous job. Lots of us have been in the team for many, many years. We love it with an absolute passion. I'm actually on leave today, but I wanted to be here because I'm super proud of the service that we offer our young people and families.
Well, Benny, I think we're very proud to have you and the team within CPFT, and I know that the reach of your work is genuinely global, so you should be so proud of yourselves.
Thank you very much.
The young people of Cambridgeshire and Peterborough, but actually right around the world, the ambient model has been adopted and is having a beneficial impact. So thank you. We've got a little bit of time for questions. Anybody like to ask a question or make an observation? Mark and then Mike.
I think it was just more, which came first, or maybe one. Did the substance abuse come first and then the bullying, or did the bullying come first and the substance abuse was as a result of the effects of the bullying at kind of school?
I suspect they were independent of each other, and I think in terms of time, it's always very difficult to put a marker on when bullying started. It's easier to put a marker on when substance use started. I suspect this young person was probably quite vulnerable from a young age. ADHD makes you impulsive. You're not always the most easy playmate. And I think that, so you probably, he had a tricky kind of experience growing up, and substances are often a way of squashing that.
Okay, thank you.
Mike.
Thank you very much, and I'd love to come and visit you. Hear more. Yes, yeah. But my question was around prognosis or hope. So, what's the future for this young man or the clients or people?
This young man has really good parental support. He's very bright. I'm sure he will get to a good university. I have very, very little doubt that he's going to be fine. It's not always the case. Many of the young people we meet have devastated families, long histories of abuse, homelessness, and are much more enmeshed in exploitative networks, gangs. And for them, what we're really trying to do above all is to change their relationship to help, so that they're probably going to have difficult times, but will they turn for help with a reasonable expectation that somebody will look them in the eye and go, I'll try. And when we meet a lot of those young people who are at the more extreme end of what we do, that is not how they address themselves. Help requires that they find a solution, or they seem to choose extremely dangerous routes to find help.
Thank you. Anyway, wish Flo this as well.
I don't know if I'm allowed to speak. I just think it's a wonderful story. I was just going to say that it's just an example of how in mental health at the moment we're coming in, if it was general medicine, sort of end stage disease, because if this boy's ADHD had been detected early, all of these sequelae could have been prevented. And I know that's what we're all struggling with, is earlier detection, early diagnosis, rapid access to services like you have. So in a way, in the future, ambit, well, it will always be needed because there'll always be people who will slip through the net. But
I couldn't agree more.
Yeah.
That early detection would have made a huge difference.
And that's,
probably would have
obviously.
never been.
And I think if you look at, the ADHD task force, in a way, it's a kind of ambit. The ADHD task force report, in the two parts of it, it pulls in all those elements of education, social care, family work. So I'm sure it's been inspired by ambit, but saying actually you need all of that stuff early on with ADHD as well as the
Bernie, you look poised. You were nodding violently. Is there anything you'd like to add there on that?
I think that we, because of the relationships that we build with our young people, we're very privileged to hear onward stories. And in fact, I had an email only last week from a young person who we'd worked with to 2016, so 10 years ago, who was applying for immigration status to move to Florida with her fiance. So we actually keep connected. We encourage young people to stay connected with us as much as they want to share, the positive, good stories, and also to seek help from us going forwards. We don't sort of disappear when treatment journeys finish. So we will always reopen a case, or we will support the young person in finding the next bit of right help for them. And we have, I can think of 3 young people that I've worked with over the past 15 years who have actually gone into mental health as a career. Somebody who worked for the trust. And that is just, it's mind-blowingly amazing, really, isn't it?
No, it's a great gift, isn't it? Did you want to come in?
Yeah, thank you for a brilliant presentation. It's always incredibly heartwarming to see the difference it's made almost every day to people. And I think, Dickon, it's one of those things that often organisations can take for granted because they just believe that there is those support mechanisms out there. But that comes at a fundamental toll to clinicians that to manage the risk. It's absorbing and dealing with a lot of emotional distress and a lot of quite dangerous environments that people live in. So there were 2 questions, if I may. One slightly controversial. So the first is a simple one. You get the support that you need as a team from each other and from the organisation. And then secondly, maybe the controversial one is, as we enter a digital age of more digital being aligned to access to services and for people to approach digital in a slightly different way, are there any risks that you can see? Because you used a phrase by looking somebody in the eye and giving them that level of hope, that connection. Sometimes over a screen, you can't feel that. So I just wondered if there was something in there that you could help me with those 2 questions.
I mean, controversial answer, but yes, I think our team does get the support we need to do the work.
Good to hear. Good to hear.
Bernie, you're the team leader. I think this team has been, deeply supported over many years in a way that is, we couldn't have developed a service that is quite unusual for substance use services across the country to be so integrated with sort of psychiatry, mental health, and wider work, rather than being focused very much just on talking drugs and alcohol. The digital thing, for us, the digital risks are that many of the young people now no longer meet shady dealers down dark alleys. They just buy a Tor browser and get onto the dark web, and it arrives at their home packaged, and they can go onto dark web shops that give star ratings for dealers from other consumers. So the kind of access to an unbelievably dangerous range of drugs has changed, and a lot of their access now is digital. And actually, it's interesting. We have a phrase we use occasionally. We call it "doc in a box." So for some of these young people who really have very shattered attachment systems, they find it incredibly difficult to trust. They can make a great relationship with one of our workers, but the idea of coming to see a psychiatrist, not so keen. The idea of coming to see a psychiatrist with white hair and posh voice, even less keen. But when the worker says, look, we can do this doc in a box thing, I'll come to you, I'll open my laptop, and he'll be in the box. If you don't like it, you can just shut the lid. He's not going to do.
Is that available for other?
We can be placed well. So how I use virtual consultations in that situation is I really rely on my colleague in the room to give me feedback on what the emotional temperature is that I might not get. But actually, for many young people, they say that helps them stay calmer because they've only got one person in the room with who they know quite well. And this, I don't think I'm threatening, but I get it that I can come across as powerful and whatever. I'm far enough away that they can speak in a way that they often say is actually weirdly easier. So we don't do that all the time. My preference is always to be in a room with somebody, but actually online is not devastating for many adults.
Can I add, Dickon, that it's a really interesting conversation, and this has been a radical sort of shift since COVID. When I remember thinking, how on earth can we continue to do our job without sitting with young people? From COVID, we now offer what we call a blended approach. So we give the young person the choice. And they can choose telephone contacts, they can choose face-to-face contact, and they can choose this, the online, the Zoom type stuff. And they utilise all of that. And in some ways, my reflection is that my assumption was the online, the remote stuff would be very difficult, but for some young people, it's actually a preference. Yeah. So again, what we do is meet their needs in that way. So they might choose that every fortnight they meet face to face with their key worker, and in between a phone contact or a Zoom contact is actually enough. But it's their preference. It's not for our ease. It's for their preference.
For the IT people, I should say we do use Teams, not Zoom. But
sorry,
yes. We never use Zoom.
This has been absolutely fantastic. I've had the privilege of meeting with the team, and it's a team that people want to join. You have no problem with recruitment, I think, because it's got such a fantastic reputation in terms of the work you do, the impact you have, and that's a great thing to have in your workplace. But even better is the impact you have on the young people and their families that they work with. So thank you enormously, and I would encourage colleagues who've not had a chance to meet with the team to please do so. You'll be inspired and you'll learn a lot. And whilst Dickon was very kind in saying that we are supportive, we also have a few stones in the shoe where we irritate you as an organisation, I know, and it would be strange if we didn't. So we will try to get better. That's our commitment. So thank you hugely. And sadly now we have to move along, but wonderful to have you.
Thanks very much indeed, everybody. Bye-bye.
Bye. Bye, Danny.
Bye.
All right, everyone. We have a lot to go at today, so really appreciate if you can help me to land the meeting on time, because we've got another important presentation to bookend the day, as I said at the outset, around children's services, which is about we'll be leading with another colleague. So today I've not been notified of any absences. We've got three. Robert Hill, who might try to join online, but possibly not, is an appointee. And Pre, one of our non-execs, will be joining online. To go to declarations of interest, any new ones discovered? No? Fantastic. Then let me take us to the minutes of the last meeting on the 28th of January. And we'll go through those for accuracy in the first instance on page 1. Page 2, page 3, 4, 5, 6, 7, 8, 9, 10, the long meeting, 11, 12, 13, 14, and 15. So we're agreeing that that's an accurate record of the meeting. Fabulous. Thank you very much. We go to the action log. And the one open action, Holly, continues to be the ECT provision in the south of the county, where we're told a business case will be developed by July. Is that still the case?
Possibly not. So Robert and I have met with the ICB and have another meeting planned the week after Easter, because I think we recognise that actually to do an in-house facility will cost in excess of £1 million, which is a lot of money when we know that there is theatre capacity available within other organisations. So the ICB have committed to having a joint meeting with ourselves and the execs of other organisations so that we can try and unlock the theatre capacity that we require to deliver ECT in the south. Because I think from a system perspective, using that amount of capital for a facility that actually we need for 6 hours a week is possibly not going to be the best value for money, and that we really need to try and ensure that the patient safety risks are really identified and looked at in the whole, along with physical health. And it was really helpful having Robert's view in terms of that sort of best use of resources and that sort of financial efficiency.
And worth for those joining us online to stress that an ECT can be both a life-changing and a life-saving treatment, and therefore the fact that this has been going on for years, trying to get access for 6 hours a week to theatre. I think if it's a physical health illness, it probably would not have taken this amount of time to get the solution. So let's hope that that can be pushed forward. If there's anything we can do further with the ICB, please let me know. To make my voice heard even more in that. So then we move on. I've notified any other business. So we go to the Trust Chair's report, which I am going to keep very brief in the interest of time. And actually, it's just a couple of things I would draw attention to, which aren't in my report. Last week, we had the publication of the first report from the COVID-19 inquiry. I think it's worth just pausing on that in terms of the report drawing out the conditions which led to the NHS being in a fairly powerless state to respond to a pandemic, and that the response was based on the way in which staff stood up and stood firm to say that we have got to provide a capable level of capacity for people who are suffering from COVID. So I think our thanks go to the very many of our staff who did step up and stepped in, not without consequence or impact for them in terms of long-term impacts. We know that. We have to look to the future to say that pandemics don't necessarily occur neatly every 100 years, and it's in all our interests to make sure that we are prepared for serious incidents of any type, and to take learning from that inquiry around how better planning and better preparedness must always be the way forward for the NHS. And this week, I draw out for your benefit the King's Fund report, and it reported a little bit in the media today, a survey they do every year about the sentiment and levels of satisfaction to do with the NHS. Whilst there is a slight uptick in this year's survey, it's from a historically low base over the 42 years of the survey. And drawing together this theme of today, which is a little bit about young people and children, what the King's Fund are finding is that young people are the most pessimistic about what they can expect from health services, that there is a marked lack of optimism that they will have access to good services. And I think it is really incumbent on us all to think about why they might feel like that, and if in fact it incentivises people to seek precisely some of the services that Vic and Bernie were talking about, and to really be challenging of ourselves as we plan for new services for children and young people, try and get a little bit of confidence and optimism back in there that the NHS is designed for everybody, and it's not simply for people in middle age or older people, that younger people have got to have that confidence as well. So I will stop there and hand over to Steve for the Chief Executive.
Thank you, Chair, and good morning, everybody. I'll take the report as read with a couple of highlight points in terms of areas of either new development or points of focus. So I think the first point of focus is certainly this last couple of weeks. I'm delighted to say that we as a trust have launched our new strategy, or strategies rather, which has been a suite of strategies that has been aligned in the equivalent of a bit of a triangle. And the reason for doing it in this way, and not being apologetic at all about this, is we wanted to make sure that the organisation, before it had a trust strategy, had a clinical strategy that underpinned it. That was fed by then a health inequality strategy that had a real sense of population move over the next 10 plus years, and a real sense of the voice of our clinicians and our teams as to what challenges they were currently facing and what opportunities that they may have in front of them. I may be slightly biased with what I'm about to say. I've not seen a strategy of a trust be formed like this before. So I am really pleased to say that what this is an inverted triangle where our clinical strategy is at the top of this, clinically led organisation and managerially partnered to deliver the best care that we can, tackle some of the inequalities that we've got, and work with our partners in commissioning and our partners outside of this trust to try and deal with some of the stubborn health inequalities that exist. And they are in equity, in access, and they are also in terms of our deprivation indices and the environments that we work. In that space, I'm also delighted to say that in the inequality space, the organisation has achieved anchor status and also has achieved social value accreditation for its role in the community. And that's incredibly important, that we don't just provide a sickness-based service, we provide a service that deals with prevention, that gets involved in communities. And most people around the table will know that certainly our sector, and Dickon, you touched on this with your team, most of the people that we see don't just come with a presentation of a requirement for a sickness response. It's more societal, it's the environment, it's relationships, it's education, it's housing, it's all of those things. So actually being a holistic provider to work with people to re-normalise those issues, to allow people to go back to home, and also try and support them with other agencies to deal with those issues at home is what we're about. So I'm delighted to say that social value accreditation has given us the confidence that we are in that space. Those two things then add up to a 5-year vision of the organisation, which is our first half of the delivery of the NHS plan, which is a 10-year plan. And again, throughout that document, you'll see the reflection of some of the things that is required from a national point of view. So this is the 3 areas of objectives within the NHS plan, but also what you'll see is the fact that that's been tailored by our local need. That's including what we want to do as a provider, where we want to go, some of the issues that we've been dealing with that we needed to fix, and we need to be honest about some of those challenges and continue to address those and work through those. And a big area which I'm delighted to see on is a shift in the positive nature of culture across the organisation, trying to improve where it is that people work, not what we do. So all of those things connected form a wonderful, very quippy phrase, which I've stolen from somewhere, so I apologise, called QPR. It's not the football team. It is the quality, performance and resource management of the organisation that add together to form a critical triangle of getting it right for those we serve, getting it right for people who work with us and for us, and also making sure that we manage whatever it is that we're in responsibility of managing. And we will not always get that right, but we will endeavour to make sure that every time we don't, we learn those lessons, we focus on where those gaps are, and we build on those for development moving into the future. That is against a backdrop of a very turbulent NHS at the moment, going through quite a lot of change. And so thoughts and minds go out to those agencies within change. So this is Department of Health and Social Care, This is NHS England, ICBs and regional colleagues, of which we're talking about commissioning checking its attitudinal approach. We're talking about regulation and oversight of performance, changing its also approach, and all of those issues trying to be dealt with alongside trying to innovate and create better NHS for the future. That said, our little part of the NHS that we are privileged to lead is making some improvements in there, and I won't steal the Chief Operating Officer's thunder, but I will say that you'll see that the National Oversight Framework, the NOF as it's called, has got some real optics in it around access points, performance points, and I'm delighted to say all of those are on a forward trajectory and in fact have improved significantly over the last 3 quarters. So our operational performance is sitting in NOF 2. For those of you that are not sure what that means, is there are 4 of these NOFs. NOF 1 is best, NOF 4 is not so good, and NOF 5 is when you need some significant support. So to move from NOF 3, which is middle of the pack, into NOF 2 for those, sounds like it's more than a chart. Actually, it's more about what we do every day for our patients and our staff. So that's something to really focus on. That then is a segue into our submission that we made, which is an integrated medium-term plan. So the integrated medium-term plan is our forecast of sustainability and that QPR model, again, the quality aspects that we're trying to address and identify improvements in our performance. And that just isn't in transactional performance, that's in experience, that's in cultural performance, and we'll touch on some of that later in the agenda. And then our resource management. I think it is fairly safe to say that I don't think any NHS organisation at the moment is finding the resource allocations easy to manage because increase in demand, increased acuity, and a lesser ability to respond to that with just throwing demand a bit. However, productivity is really important, efficiency is super important, and every time we do that, obviously we improve what our offer is. So you'll hear more about that as we get into the finance report later on, with our month 11 moving to month 12 position. And also you'll see, as we start to report into next year, our trajectory towards delivering our cost improvement programme, and the word transformation will appear on a very regular basis, but that can't be just lip service to the word. So you'll start to see areas of change across the organisation. I just want to draw out a couple of points of attention on item 10 of my report, which is the modern slavery statement that's contained further on in the agenda. So I won't touch on that. It's a really important subject to make sure that we demonstrate our compliance with that, but also more importantly, we truly believe in that and the access to those partners that we work in. We also expect them to sign up to the same thing so that we wouldn't work with agencies that didn't abide by those rules. And that also includes item 11, which is actions to tackle both institutional and non-institutional racism by being an anti-racist organisation across all of the areas that we work in, and again with our partners. And some of the issues that you've seen across either conflict in the Middle East or conflict actually close to home is always an incredibly difficult challenge. However, we are not tolerant to any form of racism or discrimination in this organisation. I just want to make that really clear, that we are an organisation that strongly stands by this and will continue to do so. I'm really pleased that the Institute of Health Improvement and the Institute of Health and Race Observatory is going to be working with us in the new year to try and encourage and strengthen that approach and really give us a test, actually. No point marking our own homework with this. We want people to be able to give us feedback and give us a challenge, because that's the best way that we can improve moving forward. I'm very happy to leave the report there, Chair, and answer any questions. I'm conscious that we've got a busy agenda.
Just to know, I think you're referring to the financial new year, not waiting until 2027 for the Race and Health Observatory to come to us.
No, April. Thank you. In the next couple of weeks. Let me be more specific.
Other thing is worth just adding to that, we should note, I think collectively as a board, how abhorrent it is to see an attack on ambulances in North London, which appears to be driven by unspeakable behaviours and thoughts on the parts of others. So to the colleagues who are trying to face into that, I think we should extend our sympathies and just say that we're thank you, Steve. Staying with you, we have the board assurance framework.
Thank you, Chair. Again, in the presence of time, I'll just give a quick overview of this and then open to any questions. Fraud assurance frameworks, BAFs, as they're routinely called, are a composite of strategic risks that the organisation deals with on a routine basis. By the nature of the BAF, these things are not supposed to be seen to change frequently, and if they do, then that's actually a worry in its own right. So in these strategic issues, some of the key worries that we've had as an organisation are included in here. They keep a watchful eye, and we're very observant to those. Our external relationships, really important as we move into this next phase of the NHS. It's really clear to me that it's no longer politics to work with your partner. It is much better for patient care if you encourage organisational partnership, and I mean that in the nicest sense. And as the NHS gets to a point where finances become very difficult and performance targets become very granular and league tables become publishable, sometimes it is really easy for behaviours to shift into a much more prosaic, isolated approach, and therefore we must rise above that and make sure that we are working with our partners. Over the last couple of months, I've seen this organisation lean in very heavily to some of our acute partners that have struggled with their capacity, whether it be norovirus, whether it be ambulance waits, whether it be winter pressures, and a significant thank you to our operational teams who continue to do that, both on a daily basis, but also at times of significant need. It is still a worry around the changing face of commissioning, strategic overview, performance, scrutiny, etc. However, I'm delighted to say that's starting to settle, and our new ICB met with them yesterday with the rest of the chief execs of our leadership community, and it was really clear that they have a real sense in mind as to direct improvement for populations, and they've got programs in place of whole-scale change, which are working with providers and are clinically led. So that was nice to see, nice to hear, and in fact I've invited them to come and talk to us as a board around some of those initiatives over complex illness. Some of the metrics that they're starting to use also have changed, because clinical feedback has given them a sense that those metrics were numerical and transactional. They didn't relate directly to outcomes, and therefore, why don't we start thinking about actual experience and outcomes? And that was a really good thing to see. So, for instance, one of those key metrics that was going to change was reduction in people using inpatient facilities. Well, you can't do that, because if people need to be supported, then they need to be supported. However, our length of stay is something that we would like to think about, because I'm sure colleagues clinically around the table would say anybody that is a day longer than they should be in a hospital is not the right place. And therefore, I think working with partners to do that would be incredibly important. The final thing I'll just sort of touch on with this is those partners also extend to non-statutory agencies, including the voluntary sector and charitable sector, including our local authority partners. We're all in this basically together, because we're all in this for the resident. And if anybody decides that we're not in it for the resident, then we're probably in the wrong business. So it was really good to hear that yesterday, but happy to answer any of the questions or ask colleagues to answer their own questions and their areas of respective staff.
Right, I'm going to bring in Steve.
Yeah, thanks, Steve. I noticed, I think we're going to see the BAF at our next public board meeting in June. Just wanted to check committee's 11 opportunity to see it in the lead up to that, particularly audit and assurance, I expect. And the second, just one, maybe as part of the refresh on effective patient care, which is the second of the risks, how that corresponds. So it's a red rating at 16, I think, current risk score. Does that correspond with what you said about the NOF performance? Is that a consistent reflection of where we are on that measure? And there's also, I noticed in the actions, 3 of the 4 actions are green, the other one's amber. Maybe shift the dial on that. Do we need to look at other actions in order to bring that score down?
Sure. I'll answer the first, then open that to exec colleagues to support you with that. I think, Steve, in terms of board committees, this should be on your agenda on a routine basis anyway. So my expectation is, as chairs of the committees, that you'll have this in your sights and will proverbially test your own area, but also the other areas. So if that's not the case, please Natalie, support that with the committees. And then secondly, I think there are a whole variety of issues that will directly affect our performance, some of which are within our control, some of which are without. So if I can just ask our Chief Operating Officer, Chief Nurse, can you two comment, Rachel, Holly, on that in terms of patient experience?
Yeah, well, initially, as referred to earlier, in terms of the NOF and the waiting time, certainly we're seeing vast improvements. And obviously there's the practical areas in terms of children's ADHD, which Dickon referred to earlier. Polly, do you want to add?
Yes, I suppose the area that I think has a huge impact on patient experience is getting our patient flow right. So actually, trying to ensure that we've got beds available when patients need them, but also then making sure that we've got a really clear discharge plan and the support services to wrap around individuals. And linked in with that is obviously reducing our out area placements, because we know that impacts patient experience.
And I think I'd come back there, sorry, Steve, in terms of,
Just speak up a little bit.
sorry, in terms of flow, it's also those patients who are clinically ready for discharge and escalations to the local authority, as you referred to earlier, Steve, the importance of that partnership working.
Thank you.
Mark.
Just to confirm, it does come to every committee. So we've made some recommendations for how it can be enhanced. I think it is true also that I think the operational type metrics, they should be validating the risk levels or saying the risk levels aren't where they should be. So I think how they connect over time would give you comfort. Yes, we have the right risk, or no, there is something else. And I think gaps change over time. So again, we need to make sure that, again, it's a living, breathing document. If there's new gaps which are identified, we reassess the risk level, we then record them down. If gaps get closed, then of course they should be removed from the documents. It's really helpful. Thank you.
Karen, and then I'll have to move us on.
Yeah, can I just ask if there's a comment about our community patients? Because I know we've focused the comments on inpatients. We have a significant number of patients in the community. If there's any comment you want to make about patient journey and patient care for those in the community?
So I will, Karen. I think for me it's about those networks. So really thinking about one of the areas of transformation that we're going to be focusing on for this current year is around our primary care mental health services. So actually making sure that we understand the needs of our population, also understand what is really difficult for our primary care colleagues, what are they looking for, but also making sure that we have really uncomplicated links to the services. I think sometimes the NHS is really good at sort of overcomplicating referral routes in, etc., and sort of re-triaging, etc., and really thinking about how we bring in that trusted assessor model, so that patients are sort of seen initially, tell their story once, and then we can really clearly get them into the service that's going to be most beneficial and give them the best outcome.
I could just add to what Holly said, just to let the board know that our Associate Medical Director, Deemer, who is a GP by background, is leading on the primary care strategy, which will actually encompass much of this.
And of course, we must stress that links between not just mental health, but community-based physical health as well. Our parent will forget 50% of what we do is physical health. All right, thank you very much, Steve, for that. I'm going to move then to quality, safety and patient experience, and Mike, to get your update from the subcommittee in the first instance.
Thank you, Chair. So I'm reporting on the Quality, Safety and Patient Experience Committee that met in February, on the 18th of February. And if I may just pick out a few points. For the avoidance of doubt, we look at the operational risk register and the border storage register on a regular basis. And that's where we start our committee. We then look at the integrated performance. We've picked out some of the points. The ECT, Electroconvulsive Therapy Service in Peterborough, was accredited, and the accreditation was welcome. So that gives assurance that patients who need ECT in this county get it. However, it is not satisfactory that patients in the south of the county have to travel north for 6 or even 12 treatments, and it's an hour each way. So just to emphasise the point that there's a quality issue about not having ECT in the south of the county. And it's not referenced here because I've referenced it before, but we do not have female psychiatric intensive care beds in this county. and therefore these patients have to be treated outside, and that equally is not safe, and the outcomes. We've talked about longer length of stay, and there are two quality issues there. One is people being in hospital longer than they need to be, but also we want to make sure they're not discharged prematurely and then have a readmission down the line. So we're looking at that, and we've already referenced the ADHD weights, and I think we're in a good position, notwithstanding the length of weights, that we're plugged in for the ADHD task force in terms of how we address that. Our process for quality impact and equity impact assessments. This is in the context of our financial resource position. So as we make decisions to manage within our resources, both workforce and money, we do that fully sighted on what the consequences or the impact of those decisions are from a quality and equity point of view, which means we can not do something if we think the impact is great, or if we do it, we are clear as to what the mitigations we are need to put in. Protect quality whilst managing within our resources. That process has been strengthened, and the trust auditors are currently reviewing our QIA process, and we will continue to give consideration to how this process can be improved over time. The quality report, the one thing I want to draw out there is complaints. We have seen an increase in the number of complaints that this organisation has received, which is not a good thing. And in terms of timeliness of response, we are exceeding our own target, which is 60 days for complex complaints, and most of the complaints are complex. However, the process that we go through with complainants is important, and the quality of the relationship that we establish in terms of getting a satisfactory outcome can take time. So we need to balance the timeliness with the quality of the response and the learning that we take from that in terms of patient safety and patient quality. We regularly look at the CQC well-led improvement plan, and we also have internal quality assurance visits, which give us an internal assessment of how our services are doing. And we've had two recent CQC visits, one to S3, which is female adult ET disorders, and the other was to the Hollies, and both CQC ratings were rated as good. We had our regular safeguarding report. I think the issues there are around making sure we're compliant from a statutory point of view, but we recognise the resource pressures, and in particular the resource pressures on our colleagues in the ICB and their ability to discharge their statutory responsibilities with regard to safeguarding. And there is a link to modern slavery because our safeguarding team has to be cited on that, and they are. Patient safety incidents are regularly looked at, and I'd just like to draw out with regards to the medicines. We have now got an appointment of a medication safety officer, and there was a call to action nationally to look at antimicrobial stewardship, which we are responding to, and in terms of governance, board oversight of that will be through the Quality Safety Committee on behalf of the board. In terms of audits, we are participating in all required national audits, but this year we're going to be looking at not just participation, but looking at the audits that demonstrate completion of audit cycles and quality improvement. So on the back of the audits, we use that to drive quality improvement, and that links to our quality priorities. The mental health report, there was an issue with compliance with mandatory training for mental health issues, and so we're looking at the method of delivery of that to make sure that the training is delivered in a way which is fits with the busy lives of our staff. Substantial assurance from our learning from deaths report, and we oversee the policy, standard operating procedures, and compliance reports following service visits. Just to wrap up, thanks to Rachel Gom, Kathy Walsh, and Holly Sutherland, who support this committee so well. And looking forward, I think quite a lot of that focused on mental health. As the chair you highlighted, we do provide significant physical health services, and I think we need to keep an eye on the degree of attention we give to mental health, which can be quite pressing, with our services, diabetes, cardiac rehabilitation, dementia, palliative care, and I think we'll keep coming back to that to make sure we give proportionate attention to the whole range of services we offer. I hope that was.
Thank you, Mike. Any questions for Mike at all from his very comprehensive report? In which case, let me thank you and pass to Rachel for the quality report.
Thank you. As always, take the report as read. There are 3 areas that I would like to. Sorry, my voice normally doesn't carry. 3 areas that I would like to highlight for the board. One is in terms of an alert for the sexual safety training compliance. That for within our older people's services, that's deteriorated since the new training needs assessment changes came into place in January 26. That's the reasoning behind it, as some of those teams within OPAC Directorate have been added to the compliance report, which is watered down. We are validating that information as to whether those teams actually do need to do that training. That said, we do now have a sexual safety trainer in post, and the longer term plan for improvement is for sexual safety training being incorporated into the personal assessment risk training, which is commencing early April. Which says that's very positive, so we're hoping to see some changes there. The second point to highlight, Mike has referred to the complaints process. We've talked about this a number of times, not only in committee but also at board. And as described previously, there's been an improvement plan for some time to improve the efficiency of the whole process, being process mapped, with weekly exceptions and escalation meetings with the directorates taking place in order to support timely submission. We very much acknowledge the balance of clinical service pressures alongside the investigation capacity for those teams. That said, we remain absolutely committed to providing timely quality responses alongside the cross-directorate learning. I would want to add that we fully recognise that further review audit is needed to improve the situation of health and complaints within the trust. And then the third point that I'd like to highlight is the continued improvement in terms of the falls work within our older people's service. That's the directorate have worked tirelessly in terms of and with the falls lead to improve that situation.
Questions? Rudolph.
Thank you. Can I just ask whether you feel you've got a good clinical oversight of the training needs analysis? So if you're a specimen of the different kinds of professional groups, that what comes out of the computer does reflect your needs, because you hinted that it might be occasionally going wrong there for particular staff.
Yeah, I think that's a very good point. Steve and I were actually talking about this earlier this morning. That in terms of project priorities, one of the project priorities for last year was looking at clinical learning pathways, and absolutely, I think there are some areas that we need to go back and validate. Is this right for the directors, and ensuring we have that full interface between the corporate team and the clinical teams. And let's see, would you like to add to that?
No, I think it's really, really good value point, and there is a piece of work. I mean, part of the training needs analysis does sort of reach out to sort of broad spectrum of clinicians. I think Rachel mentioned a really important thing though in her feedback when she said that we are looking at combining some of this, because we have a significant spectrum of training, be it mandatory for role, or specific for certain areas. And then we have CPD training on top of that as well. There is something about this organisation just trying to coalesce this down to something that's a little bit more focused, because we're asking a lot. So there's something about making sure you've got the right clinicians involved in all that piece of work. There's something about trying to just draw this down to something that's a bit more sort of manageable given the set of priorities that we've got.
Sorry, goes to Steve Cox, and Steve Grange.
Just a quick query on the clinical adverse events. I noticed the number closed within 30 days has reduced. Is that partly because the numbers increase?
think there's an increase of like 200 in January 25 and January 26. Is that
Yeah.
part of the reason?
And it is, and it's also that the process is being reviewed within dating schedule and improving.
And data, just to explain, is the system
Our
where
incident reporting system.
Steve.
Thank you, Rachel. I think just to support Rachel in terms of the update against complaints, it is an area of focus for us. And I think one of the things that's really clear is maybe subjectively, and I think Rachel's view of reviewing this will get rid of the potential for myth in this space, is that the high level of acuity is represented also in complaints in terms of the nature of people's complaints, the detail involved, which means that actually a lot of these take a huge amount of time to unpack, and people, rightly so, if some people need some support, but are using other tools to support their complaint, whether that be AI or whether that be other ambassadorial approach. So we need to make sure that we've got a service that responds to that appropriately, has the right level of time to do investigations to unpack these complex issues, and then we have the right level of learning that pops back into the organisation to address any gaps. I think in doing that, though, we need to make sure that we have a review that gives us a real sense of where is the demand going with this now, and it's not just this organisation, it's national. There is a high level of increase in demand of people's expectations, and I think we just need to make sure that we've got the right support into the team that do quite a difficult job most days.
Thank you. Are we able to move on then? And Marianne, our Director of Operational Finance, will begin with financial report.
As noted in the report, the last report, that at month 9 it was a 3 million deficit, and the run rate was 51 million from that month onwards. At month 11 report you've got now, I'll take the report as read, so I won't go through every figure on there, but you can see there that we haven't quite got a 1 million deficit run rate. It has reduced slightly to 1.6 over those 2 months since the last report from there. But we are expecting that to reach 2, and as under finance nuances, you can see for the first time we've been allowed to report our forecast for the end of the year. There's a 5.5 million deficit, which is what we are expecting. Whilst that was shared with the ICB previously, this is the first time officially we've been allowed to put it into our monthly reporting back to HSC. As you can see from there, I think in the previous report we reported the cash balances were declining. We have had significant movement, especially with the Peterborough and Cambridge ICB, in recovering some of the debts, and this was unblocking some issues we've had where they're querying individual invoices but aren't paying for the whole service invoices that we've been for. Lots some issues around invoicing as well, ensuring that we had contracts signed to enable us to raise those invoices, which has also resulted in some income coming in that we didn't have in previous. So the cash balances have increased, but that also links to our capital expenditure because we've reached some public dividend capital to fund the estate safety and some of the digital schemes we've got going on from there. In regards to capital, the story is the same as you had at month 9. We're looking like we will be on track for year end. We are slightly overspent at month 11, but we're doing various things within the finance and how we can delay some things to ensure we actually hit that. Efficiencies, again mentioned previously, have been supported by non-recurrent monies, and obviously the team are working hard with the transformation and going forward into next year and how we make sure those are recurrent efficiencies from there. I think for the pack, the first time we've seen some whole time equivalents included, just to state for Stephen's benefit there, that is the pure ledger data that's been downloaded, so it's uncleansed data in that sense. So we are working on that, but Robert felt it's important to bring that to this forum as well, alongside the pounds, so you can see the correlation and drive some graphs. So that's the work in progress from the finance team. I think it's just fair to say to the team, they're undergoing their interim audit leading up to year end. As we mentioned, first next week, so they're in close down a month. There isn't anything significant that's coming out of the woodwork at the moment. But what we are trying to do is close out everything that we can. Make sure we've got everything accounted for in this year so there are no surprises next year, leading into us a good place to start the new financial year. That's it, unless there's anything.
Thank you so much, Marianne. Admirable clarity. Steve, do you want to add?
Just a couple of points, please, and hopefully Marianne will correct me, and then Robert will correct me afterwards if I get this wrong. There were a couple of things in what Marianne's just said there which are really important. One of which is the declaration of our Monthly 11 position by NHS England. So I want to make a formal note of thank you to our ICB colleagues for working with the Trust on gaps in income, where we believe that there are discrepancies against contractual income lines that we are having with our ICB colleagues commissioning. That's not helped with some of the changes that have been wrapped around the ICB, but I met with a lot of colleagues yesterday and we talked about the fact that we're seeking resolution to that very, very quickly. For us, that goes into the millions of pounds, so that there are significant areas of concern for us there. But it was met with a level of pragmatism by the ICB yesterday, which I was grateful for. The second is our expenditure against our run rate. So one of the areas that you'll see is focusing on, certainly as we go into the latter part of this year and into the beginning of next financial year, is that we start to look at our expenditure against our run rate. So when Marianne talks about non-recurrent money, this isn't money that's just to one side. This is where the organisation is not expended or is holding on to things such as vacancies in the traditional sense. This is when we get into the transformation space to make that recurrent. So we would start to look at redesigning the service offer that we've had rather than live in this non-recurrent space, which is not uncommon, I have to say, where we start to look at areas of expenditure that are probably higher than we would like. And then the final thing, which probably for me is most important, our savings plan for this year. So you'll be conscious that we had £17.6 million worth of cost improvement to make. Won't go into the detail of what cash out has been created from that, as in savings, but there have been a significant number of in the millions of pounds of cost avoidance. Now that cost avoidance doesn't relate to cash out, and what it does is it stops you expending more than you should, but that still means we're spending more than we should. So I think what that's been able to do is to slow down that expenditure above where we need our expenditure lines to be, with a real sense of that locking into our new efficiency plan into the next year. So there's been a huge amount of work, and I just want to say, pause for a second, a big thank you to both the operational directorates and our services for being able to support us with our financial efficiencies this year. It's been tough. Some of that has been with different levels of information as we've started to strengthen our governance arrangements and understand what is true north in some of these areas, which has been incredibly helpful. And that leads me to say a significant thank you to Marianne and the team, finance and the team, who are trying to unblock some of those issues that have probably plagued the organisation for some time. So really good to start to see some solid foundations in place now moving into next year. That said, next year isn't going to be easy, but that's part of the job. So I just wanted to say thank you on that.
I think we'd all echo thanks for the questions. Mark.
Just to clarify on the part regarding the income, whether how much the ICB are paying, the numbers within our figures, is that what we think we should get or what we are getting? So in the next couple of months, could it actually be worse if we don't get what they should be paying us?
So for 25-26 is what they should be paying for us.
Okay.
The discussions around the outstanding debt are going well on that. Today is actually the last payment day for NHS to NHS, so we're expecting to see quite a few outstanding debts that we're dealing with come in tomorrow in our bank in that sense. Going forward is what Steve was relating to, and that's the income triangulation that they do when we submit the plan. And we had to resubmit with the difference with the ICB going in. I had cleared that with NHS England because we couldn't get anybody from ICB to respond to us. And they were happy that we were putting that in, and that will come back out in the triangulation exercise. But the conversations and escalating meetings are still ongoing. And as Steve said, the Chief Executive was discussing that yesterday.
Do we have any timing where we think there could be some resolution? Because in some ways it then tells you whether you have more efficiencies to get, or whether in fact you move from a hopefully balanced position to a not balanced position.
I think from certainly what was said yesterday, there is no organisation around the table that's got a confirmed set of numbers yet. So I think as soon as possible, but it was recognised yesterday that this can blow people out at about month 3 if this hasn't been locked in. There's a fundamental difference that we need to adopt here, which is the difference between cost and price. And so I think if the entire system is operating in a different model of cost and price in terms of the running cost of services compared to the actual price of services, that's the bit that we need to get close to very, very quickly. But certainly within the first quarter, we need a real clear line. Otherwise, we're going to have to take additional efficiencies in the event that that's not resolved. I feel, I'm not going to use the word confident, but I feel that the challenge between ourselves and our commissioning colleagues are reasonable, is probably the way to put it. And in the event that that reasonableness can't be enacted, there is a way through for us to not deliver on some of the stuff that we should be doing that we're not getting paid for. Thanks.
Any other questions on this? I mean, I think, first of all, let's say huge thank you to Marianne and the team and to Robert in his absence for bringing some clarity and discipline to bear here. It's very welcome. But we also need to remember as a board, we have a legal duty to balance budget, and we have to ensure that we do that whilst maintaining high levels of safety and quality of services. So those are the fundamental duties of the board. We go into 26, 27, knowing that we've got some challenges on all sides there that I've talked about, quality and safety, and the balancing the budget, and we've got to go at this with pace and determination to make sure that we actually arrive at a model that is affordable and is always prioritising the people that we serve in the best way with the resources we've got. Okay, then we move to the People and Culture Committee report, and Pri, you're joining us online.
Yes, apologies that I couldn't be there in person. Thank you, Chair. I will take the paper as read, but just pull out some of the key points from our last committee meeting. We did agree to, well, we noted that we've slightly reduced the risk around vacancies, and that came about because of the use of the vacancy control panel. We're very conscious that there are financial challenges and challenges around the safety of the staffing levels, but that the process was being well managed, which is why we were comfortable to see the risk level drop on that. We did note that the overall appraisal rate has dropped again, and it is a cause for concern. Now, obviously, we understand that with turnover of staff and the current challenges that it's not always easy, but we did note the importance of holding those regular discussions with staff. So we'll be looking to see those increase over time again. We talked about the gender pay gap report, but gave it a partial assurance for now because some more work needs to be done on the data before it comes back to us. But the committee did note that there would be a gender gap because of the makeup of the workforce and the gender splits at different levels of the organisation. We noted the good work that's continued to happen within the organisational development team, so in terms of developing staff and the organisation and the way it works, and there's some talk about how to ensure more of that is embedded as business as usual. We looked at and noted the good work done by the peer support workers, which is an incredibly valuable service for our users. We did talk briefly about the staff survey and noted the increase in the response rate, which was helpful, but that there were few improvements overall. But I know that's going to be discussed as a verbal item later, and I'll stop there. Thank you.
Thank you. Any questions on Pri's report? A number of items under People and Culture today. Okay. In which case then let us go, Stephen, for your report, which is the full report.
Lovely, thank you very much, Chair. So I'll just draw out 3 or 4 sort of very particular points. 2 sort of slightly more combined, and that is around sort of procurement process. So the HR team, supported by a number of individuals in the organisation, have gone through a procurement process for a new payroll contract and also a new occupational health contract. And as you can see in the report, we have been awarded to ELFS Business Services, and we're currently doing that work to sort of transfer it to them. And they've already reached out across the organisation in relation to their new portal. I think it's really important. We have seen over the last sort of 12, 16 months, and you can see that in the staff survey, some of the feedback around sort of payroll issues. So I think we're really positive actually that we're going to have a new payroll provider going forward. So I think that's really good. And then again, occupational health, that gives us a real opportunity to sort of rebase that and go forwards with the new organisation as well. And then just a couple of other points. Sickness rates you have seen have increased to 5.38%, which is above target. And again, this is sort of against a sort of a seasonal background, and it is in line with the season. If we just align that to some of the NOC discussions that certainly we have later on, then actually we remain relatively sort of, some words from a benchmark perspective, relatively low in comparison to other NHS organisations. However, we do recognise, given some of the challenge we face, that we do need to continue to work and focus, and now doing some deep dives with the directorates around sickness. And then my only other point is around appraisals, just recognising what Pri was just saying. And we have seen dips down to 84% in January. So we are doing some very focused work around this, especially around corporate areas who've gone through some, quite significant change actually in 25, 26, just to ensure that actually we are getting that target up, but moving beyond just delivery against the target, making sure actually that the appraisal process is actually right for the individuals. So we are again looking at that in a bit more detail for 26, 27. And again, we did discuss that, as Pri said, at the People and Culture Committee, and I will stop there.
Thank you very much. Questions for Stephen? Mike, and then Rudolph.
Yeah, I was just going to expand on the what you both said about peer support workers. I don't know what others think, but these are people with lived experience of mental health who work with our teams, and I think play, and my personal view is they play an important part in providing the care that we want, the best quality care, so it complements our clinical colleagues. And the numbers are dropping. And I suppose the anxiety I had, Chair, when we were talking about that is in the context of our cost improvement programme, saving money, to how do we need to think how we prioritise this particular thing against all the other things that we need to do or we need to stop doing. And so my point is not only quality impact assessments are important, impact assessments are important. How do we measure, and do we, either through evidence, national or locally, to make sure that we make appropriate decisions around the cost of employing these patient support workers. And I'm using that as a sort of example in general, but also a particular issue. So I guess it's not a question, but it's an point. Yeah.
I'll let Steve come back on that, and I'm going to go to Rudolph and then to Jackie, and then to move on.
I just I won't go into detail here because maybe we can pick this up outside, but I think it's really difficult to identify a clear what you'd class as return on investment for a peer support worker. However, the role that they play is really critical. And so one of the things that I would urge us to do as we get into this space is to make sure that what we don't do is evaluate something that hasn't got what you'd class as a financial return as not added value when it absolutely is. So I think one of the issues that we need to do, Mike, is to understand the role that may not be immediate in terms of impact. And certainly, I think we need to really look at this area again as an organisation. I think the peer support worker approach at the moment could be strengthened quite a lot, and something that I think we should probably encourage, but we'll work with our teams to understand what the impact of this is.
Rudolph and then Jackie.
Just picking up on the staff sickness aspect, so there's been an increase in quite a significant fraction in sort of anxiety, stress, depression. There's also a comment that we can't say how much is due to work, but I guess we could ask, do we have a sense whether there is workplace stress that is contributing to some of this that we could be doing other things about?
So I think it is a difficult one because actually, the feedback we get is there are elements of workplace stress. We also get feedback actually there's a lot going on in families, in society. We mentioned COVID, post-COVID. There's a whole set. I mean, some of the things what we do actually in the organisation is do some preventative work. So we try and do a lot of work around mindfulness, sort of mental health first aid, that sort of thing, in order to try and prevent this. Could we do more? I think we probably could do some more across the organisation. That is a conversation we're currently having, especially around sort of anxiety and depression in particular. And that is something that we will sort of bring back to People and Culture. We get quite a bit of feedback on some of the programmes we currently run. And that, as you can see in there, is quite positive in the context that it's actually helped them deal with some of those pressures and some of those issues. But actually, going back to your original question, can we sort of say is it just work related? You can see in the staff survey there are elements and there are clear some pressures and there are some issues there around burnout. So those may sort of lead into that as well. That is a piece of what we are doing.
I'll be very quick. Thank you, Irene. I think one of my observations is that we are data rich when we're looking at the workforce data in the committee, but we might be less rich on insight that data is telling us. And is there an opportunity as we head into transformation to think about how staff survey and the data that we see on a regular basis is designed in such a way to improve our insight that will inform the transformation programme, culturally and workforce related?
So I think, Jackie, that's a great question, and I can sit here and say simply yes, absolutely, because having met yesterday with some additional resources that we're bringing in, we do need to use some of the data we've got and then triangulate that data. It's a bit like, just talking a moment ago around some of that sort of impact on mental health and sickness. Clearly we've got a lot of rich data in staff survey, we've got a lot of rich data in the report. We just need to bring that in, and then we need to use that to drive the transformational change. But also use it to drive, and we're going to talk about, safe staffing in a minute. What is the staffing model that we need? It also aligns with the conversation we just had around peer support workers and how do they sort of fit into that transformed model as well. So you're absolutely right, we do need to bring that together, and that's quite a complex set of cogs that we're going to have to put into play.
And where will that action kind of materialise? Which, not putting you on the spot in terms of which committee, but where does all of that work?
So there will be various facets that will come up to people and culture. We'll be obviously picking up some of the sort of the quality impact assessments through sort of, quality, safety and patient experience. And obviously that broader piece of work around sort of efficiencies, but also the whole transformation pathway through business and performance as well. I think we probably need to have a bit more of a conversation around some of the architecture around this, and I'm conscious we've got that at private board as well.
Sorry to jump in, plus going out, touching it, feeling it, smelling it, and going to talk to people. I think that's, if we rely purely on data processes and mechanisms to give us that feedback, then we're missing something. So I think the tune in to our workforce is incredibly important.
Sorry, Chair, I'm conscious of the time, but what we didn't say, one of the things at the last People and Culture Committee, we got the feedback around the shaping our future. One of the core areas actually was around going out, engagement, and actually getting out and being seen, and that sort of active sort of engagement, not just at this level, but at levels below. That's one of the key priorities for 26-27.
Well, I'm pleased to hear that there's an intention to do that. But great questions. Thank you very much. Rachel, we'll go to you for the safer staffing.
Thank you. I'll try to talk up. I just want to, so this is the first safer staffing report that's come to board for some time. It's very important that we all understand the expectations of us as a board is set out by the National Quality Board. So I obviously the paper was read, but the background is really important for people to understand. We did participate last summer in terms of a self-assessment in line with the workforce standards. We did an internal self-assessment that went to region, and who hopefully assessed us against our self-assessment and advised, have been very helpful in advising us in areas of further improvement, but also in providing us with support for training networks for not only our safety staff for me, but our Deputy Chief Nurse, who is now on the fellowship programme. The other areas I'd like to highlight is that in terms of the assurance statement, which I've just explained in terms of saying that we were non-compliant, we are now becoming more fully compliant. And just to outline the roadmap for improvement that we've articulated here. The other absolutely important aspects are, say, this is the first safe staffing report for some time. Stephen and I are in conversation in terms of there's more validation needed and from a financial perspective too. I would also just like to give an example of in terms of where the red flags and hotspots are identified. We have had awards last week and this week identified in that with the staff team yesterday. So I think going back to what we've just talked about, going, feeling, and actually getting that first-hand feedback and discussion with the team, that was very, and this also relates back, Steve, to what you were saying in terms of quality, performance and resource. What was very clearly coming from is that whilst they have their safety staffing met, the actual acuity and complexity of the patients on that ward has increased. The level of observations is something that they have not seen before, and that obviously leads to patient experience and outcomes. What we did also see was that there had been sickness on that ward, relating back to what we were just saying, but not necessarily sickness from the starting staff group, but sickness from the bank staff group when we're using bank staff and say, actually, it's just too hot to be there. So I think that complex mix of not only the quality, performance, resource, but also demand capacity, safe staffing, patient outcomes is really important to keep in mind at all times. In terms of, I would also urge you to read the recommendations of the report. Unfortunately, here we did have detailed discussion at the Adoption Committee. Really important that as a trust in terms of our workforce planning and growing our own. We've worked collectively in terms of our business case has been already written, developed, that we now look at that in more detail.
It is an extraordinarily important report, good report, rich in data. We need to turn that into insight and action. Anybody got any questions? Steve?
Just a point to page 19, item 1, very much welcome the introduction of patient and carer race equality framework information into this. I think this is incredibly important. It's a really mature step, so I just wanted to say thank you for highlighting that in the report.
Any other observations? Karen?
Can I just pick up what is rather a tactical issue around the rostering and the fragility of it in some of our areas? And I suppose I'm asking the question from a staff perspective. We have a target which is 6 weeks, and I do wonder in terms of our staff whether that is sufficient. And I don't think there's anybody around the table who will be happy with only knowing 6 weeks ahead what their duties are. And I wonder if there's an opportunity now to extend that, notwithstanding we're probably not meeting it in some areas anyway. And I'm thinking of that also in the context of sickness. If you've got something that you've got a family event, you're going to go sick with a bellyache. And if you look at our sickness, bellyaches are quite driver. So I do wonder whether we need to look at that 6 weeks and extend it to something more conducive to supporting our staff.
Yeah, I mean, I think it's a very good point, Karen. I think there's probably 2 things for me. First of all, we probably need to look at that. It's actually relatively standard across the NHS around the 6 weeks, so we're not having to kilter. I mean, I think there is a broader thing though around just aligning it to some of the what you just said around sort of the bellyache analogy. And actually, is there a bit of work around just understanding sort of if there are some issues or if there are some drivers that do that, and is it the rostering is just 6 weeks that doesn't then allow people to plan on a long-term basis? I mean, for me then, it's probably about actually having a bit more of a conversation across the organisation and listening to what the organisation says back to us. Is 6 weeks right, or actually is it 12 weeks, for example? And I've certainly seen 12 weeks used as opposed to 6 weeks. I'm also conscious we have through the PREs previously done a bit more of a deep dive around this as well. And again, this may give us a bit of an opportunity.
Ollie, did you want to come in and I'll go back to Rachel?
Yeah, thank you, Chair. I think it's a really interesting question, Karen. I guess for those of us who are clinicians, 6 weeks has been really standard. And I guess we're used to sort of, I suppose, organising our life that way. It doesn't mean that you could book your entire year's annual leave, 12 months, from April the 1st, you can schedule your entire allocation of annual leave. So it's not that we're sort of saying you don't have any certainty in terms of perhaps special occasions, etc. I think for me, we need to make sure that we are compliant with that 6 weeks, because anything less than that, I think is really difficult for staff and not reasonable. And I guess some of my concern about thinking about extending that is that you then lose some of the flexibility if we find that actually people, we're going through a particularly high acuity phase, and or we have particular sort of bugs going around that means that you can't sort of have that flex of thinking about that rota. But I think it's a really interesting conundrum, actually.
Rachel, did you want to come back?
Just to say, I think that there's other components to consider as well in terms of foster approval, and that's if there's any unwarranted variation. And again, with having the safety staffing lead in post, that's certainly supporting the teams and the foster management. And again, just we heard yesterday, I heard yesterday from the staff team was we also have the challenge of flexible working and how to manage that in line with delivering the service. So it's a challenging area. But again, with the safety staff and lead now in post, I'm already seeing.
Okay. Well, it's a great question, Karen. 6 weeks is the standard. Well, okay, but if there's better practice out there, then we should go and look for it and find it, because if it's having an impact on our staff, then we should be very curious about that. Can I move us along to what is not going to be a full report today? It's going to come back at the next board meeting, self-survey. So who's going to do?
Shall I just open up very briefly? I'm very conscious that staff survey results for the NHS have been released, which have shown a change in some areas that I think we've unpacked in here already. And I think one of the issues that we as a trust are trying to do is to unpack our own version of that, to make sure that we've got areas of focus that we can bring back for a fuller debate when we've had a chance to look at the report in detail. Irrespective of the areas of either marginal or minimal decline or indeed improvement, I think it's really keen to say that as an organisation, culture for us is really important, and improving the experience of our staff and how they feel coming to work is a key indicator of the fact that they are bringing them whole selves to work. So against all of the sickness, the backdrop that we've talked about, Rudolph's question in terms of how much of that is work related or not, these are all proxies of the way people are feeling. So I think it's a good opportunity to pause and say, let's go and unpack this in detail and bring that back. And I can hand over to Stephen if there's any sort of headlines that you want to pick up.
I mean, really quickly then, just to say that, we saw an increase in action response rate, which is positive. We've actually I think it's fair to say we're seeing across the sort of the 9 domains, there's 7 poor people domains, plus 2 additional over and above that. We've seen a relatively sort of static picture. There's only one area where it's been statistically different. We've seen a slight drop. I mean, I think it's also fair to say we will bring a full report to board, a public board, should I say, and that we actually want to spend some time as a board sort of review. I mean, we have gone through it briefly at People and Culture Committee, and I think it was also fair to say we want to have a core set of priorities, 2026, 27. And as Steve has said, they need to be, a lot around sort of inclusion, a lot around the culture of the organisation. And as the board sort of assimilate lots of information that is obviously nationally available, we are sort of getting on with some of those core actions as well. So we're not waiting for some of the work that we need to do.
All right. Well, I do want to come back to this. Thank you. Steve Cox, can I go to you for we move into business performance section?
Thanks very much, Eileen. So this is the report from the February meeting of the performance committee. Takes the report as read. Just highlight a few areas to flag. So on risk management, we've spoken about that. On the operational risk register, we were able to agree to move some risk out. There's progress on health and safety training, security service capacity, which was good news. We've got the item on the integrated performance and quality report coming up in a second, but the committee in February welcomed the fact we're aligning this now with the national oversight framework, which makes understanding trends much easier as they're presented. And as we've already noted, some really good progress in the sustained reduction in inappropriate out of area placements and progress in other areas crisis response data quality, noting that we have done already further work to do on length of stay, but we'll go into that in the next item. Finance, we've also had an update, so we went through the month 10 position, we've had a month 11 position, so we're more up to date now after that item. Freedom of information, please, 90% of FOIs were closed within 20 days, which is good news. On digital transformation board, actually the assurance rating that we gave, as said here, it was partial for two reasons. One, we still are wanting to see an update on the digital maturity position. I think it was an action from the board as well. So I think for that to be coming to our April meeting, and also the digital strategy, I think is still working its way through, and look forward to seeing that in due course. We've already heard about the MTFP, the medium-term financial plan. So we heard about the submission of that in February. That's really moved on, and we know about the challenging cost improvement programme within that to achieve break-even in 26, 27, and as you expect, the committee will keep we work very closely with exec colleagues to support and track progress with that. I think, Chair, that's all.
Thank you, Steve. That's super helpful. Steve Grange.
Just a point, Chair, under item 2.6, Steve, which is Information Governance Cybersecurity Report. I'm delighted to inform the board that under DCB 1596, the organisation achieved a perfectly compliant score, which I think is credit to the team. Basically, for those not understanding what DCB 1596, including me, is, that is the cybersecurity report. In this modern day and age, it's really important.
Absolutely. Because there's always someone out there who's seeking to be cleverer than that. So, fantastic. Well, congratulations to the team. Any questions at all for Steve? In which case, I'm going to invite Holly to quickly go to the integrated performance and quality report.
Thank you, Chair. And obviously we've touched on it already with Mike and Steve's update, so I'll try not to repeat. But I think it's important to point out that it was the first time that the new integrated quality and performance report went to both quality, safety and patient experience and business and performance. And that enables us to have improved triangulation across the quality, safety, workforce and operational delivery, which we feel is really important, so that we're really able to consider more broadly how we're doing as an organisation. Overall performance shows a positive direction of travel, and as Steve pointed out, with notable improvements in access, crisis response and reduced out variant placements. And this is despite a sort of ongoing demand pressures, workforce challenges and some wider system dependencies. The paper articulates risks to delivery, particularly in relation to inpatient flow, workforce sickness, which we've already touched upon, and appraisal compliance and recognising that impact. It also highlights some variation in some pathways with active mitigation and system level engagement in place. What we've also tried to do in this revised report is looking ahead to ensure that we have a sort of clear and credible forward plan, which is focused on improving the areas where we know that we've got improvements to make. And so in terms of those key actions that we're focusing on currently, they are around continuing to strengthen our performance reporting and assurance, so that we've got improved visibility, accountability, and it supports timely decision making. Sustaining the improvements we've made in access, flow and crisis services. Addressing inpatient flow and length of stay pressures. So that includes bed modelling work, pathway improvements and system engagement to reduce prolonged lengths of stay. Looking at some targeted workforce risks. So again, looking at sickness in certain services, improving appraisal compliance and maintaining the grip on vacancy and turnover rates, continuing to strengthen our inequalities and PCREF data, and really understanding how we use that to develop and transform services, progressing the directorate specific recovery and transformation actions. So whilst our overall performance is improving, we do know that we have services that are under significant pressure, ADHD, ASD being a really key one, but making sure that we are continuing to look at the improvement work there, and also maintaining active system collaboration to make sure that we're fully locked into the neighbourhood work, but also understanding how we can support our other system.
Thank you, Holly, and thank you for drawing out areas of improvement, also continuing areas of challenge for us. Any questions? Mike?
Thanks very much. And certainly at the Quality Committee, we appreciated this report. Very good. What I just wanted to ask about one of the risks, if I may, which is variation in the recording of diagnosis on medical records. You pick it out as one of your breakthrough objectives, as it's called. I think that's a kind of particular focus on something. And I just wondered if you wouldn't mind saying a bit about that. As a clinician myself, recording a diagnosis is important, but recording a wrong diagnosis, or indeed recording a diagnosis where there's uncertainty, is risky for patients because they end up then carrying that label with them whenever they see someone else. So I just wondered to what extent you got clinical input into this. And as we heard with Fergus, it isn't a diagnosis. Often it's diagnoses and other stuff as well. So I'm glad that it's there, but I just wanted OPAC focusing on.
It's across all three directorates, and I might look to I might start and ask Cathy to come in, because obviously that clinical engagement in terms of diagnosis, and I think there are probably three things that I would like to draw on. I think one, because of our funding mechanisms, there hasn't been a drive to necessarily record diagnoses in a way that in our acute colleagues would be absolute custom and practice, because it drives the funding mechanism. But I think we really are keen that we're not just looking at performance, but we're understanding, are we having positive outcomes? Because you can tick the box and miss the point. And if we don't know what our patients are diagnosed with, it's then very difficult to know whether the outcome that we've got is good or not. So I think it's considered good practice for us to record diagnoses. I think the second point is we've got some anomalies with System 1. It's that age-old issue in terms of some of where we report our diagnoses. It isn't easy to pull it out. So sometimes the diagnosis is there, but we're unable to extract it. So there is something about how we make it really transparent, but also easy for our clinicians to record diagnoses. And several months ago, we approved a standard operating procedure where actually we could have some administrative support of pulling out of letters. So as long as the clinicians made the diagnosis, some administrative support could then input that diagnosis code in the right way. And I think the third point, which is probably where I'd ask Cathy to sort of step in, is about that sort of provisional diagnosis. So Mike, picking up that point on, we absolutely don't want to give individuals a label that might impact or follow them if we're not entirely sure, and we know that it can take time or there can be multiple. But I think we're happy that we should be identifying what are we thinking about for our individual patients. So Cathy, you might want to come in.
Thank you. My issues. Well, Holly, we thrashed this out, Mike, over several different meetings at PREs. I agree with you. We don't want to prematurely label people. So what our solution has been is that if we're not certain about a diagnosis, we put in a working diagnosis, and that can obviously be changed over time. But we need to remember we are an organisation that provides evidence-based treatment. In order to provide evidence-based treatment, you need to know what you're treating or think you're treating. Also, commissioning is really important. The commissioners, if we go along, say we're going to put enough resource for something, but we have no data, how many diagnoses, etc. That makes those conversations very difficult. And then we have the issues, as Holly said, about the System 1 optimization. And I might just put in a word here for Omar Agrobi, who we have recently made an appointment of a Chief Clinical Information Officer, which is a new role to the Trust. And I think he's really hit the ground running. And it's been really useful to have that more clinical perspective integrated into some of our digital transformation pieces of work. But yes, good memories. And those members of the public who think that we operate in the absence of diagnoses, can we provide some reassurance that that is not the case? We can indeed provide that reassurance. So we are seeing month on month, the recording is going up in each of the directorates. And one of the directorates, I suppose, where the issues Mike raised as most prominent is children and young people, where actually, diagnoses are very fluid over time and change. But we need to rely on the clinicians to actually, work with that, and they do work with that clinically. So it comes back to a reporting issue.
It's also important to add that patients and service users appreciate having a diagnosis, but I think they would also appreciate the concept of provisional diagnosis, that it would be taken away once they're better. So,
okay, thank you. I do need to move this along, I'm afraid. Holly, what you there? Can we go then, Steve, briefly to the update on Cambridge children?
I'll be brief, Eileen. So we've got an item shortly, which will be really important on the clinical model. But just to update where we are, so the next 6 months is a crucial 6 months because the board will be asked to sign off the full business case in September. So in the lead up to that, there'll be various briefings and items coming forward around the elements of the business case, so the strategic, the managerial, financial, economic and commercial cases that underpin or are part of the full business case. So when we see that in September, we made the point that committee about the importance of ensuring that partner decisions are made in advance. So we're seeing the final position at the FBC, so that's regional partners, commissioners, etc. The focus for the work, as you see in the report, is getting the final details on the cost programme from the contractors. Will be hugely important. Joint venture for the construction and management of the building. Operational models for integrated care will be needing to be resolved and moved as well, and research, which is really important. Research is really important. We'll hear more, I think, shortly. On the design and construction update, the moving of services away from IDA, with the point the committee made, was crucial that the transition ensures continuity of patients' services. Compromises that really important. So I think that was a brief update. We've got a clinical model a bit later, which will be really helpful discussion, I'm sure, that I'll be.
I'm going to ask if you mind we move things along. I've got the estates facilities report. Marianne, are you giving that?
I can give a brief, just give a short from that. So this is a new reporting approach, and it will come back every 6 months. Wasn't anything particularly to highlight, it's just around the operating safely and effectively, the strong compliance, stable workforce for our facility sites, and there was no emergent issues to raise from there. The top 5 risks are in there, and just there was no transcardiac surgery, just to say that their air handling was sorted in March, but I also know I'm in discussions with the states around what we can possibly do about that long-term future as well. And around the capital area, we've had good work so far this year, quite a significant amount spent on the estate, and we're now working with Alison around the plans for 26.
Brilliant. Any questions on the Fantastic. Steve?
Just as this report comes forward, Marianne, if it's possible to also include much more focus in terms of the place feedback on our environments, that would be incredibly helpful, and a compliance rating against all of our estate against place would be really useful. Thank you.
That's fantastic. Right, Kathy, we go to you then.
I'll be brief, Chair. So firstly to say the medical workforce position is increasingly positive with a relatively low turnover rate and improving recruitment. We currently have a vacancy rate of 30%, so that's consultants and desk doctors. However, if we look at the recruitment pipeline, a number of vacant posts are currently under offer. So that would reduce our vacancy rate down to 5.6%, which is really, really very positive. I'd like to highlight 3 areas of progress. Firstly, our job planning compliance is 98%, which exceeds the national target. Secondly, we've significantly reduced our locum usage, particularly the adult specialist director, where they have no locums currently, which is really very positive. What I would like to highlight is the time required to get a consultant post, which on average is 6 months. The reduction we're currently seeing reflects work that's taken place over the last 24 months, really. So this is really a sustained programme to reduce agency usage. 80% of our locums are now on direct engagement. We are also reporting an over 90% compliance with the National Resident Doctor 10-point plan. We're seeing strong progress in medical education. All our training posts are filled. There's an increase in national interest in psychiatry, which we're all delighted about, which is a very positive indicator for future workforce supply. In terms of appraisals, the data as it's presented comes from our software called Allocate. If you just look at it quickly, you would think that the completion rate is 74%. However, it's important to highlight that this is for the reporting period only, sign off. Appraisal cycles are individual to each consultant. So a proportion are actually in progress and within the allowable time frames of 3 months, which we give for the appraisals. These appraisals are different to non-medical appraisals. And if you take that into account, we never predicted appraisal compliance of 9%. And alongside that, it's a very robust governance process, in particular, it takes on our very active officer. To highlight the key risks, we have a mismatch between medical workforce and service demand, which has been identified through job planning. That will be mitigated to some extent through service level job planning, which is a national year, and also translation work. But this does remain a strategic issue for trust. There are also some ongoing recruitment challenges in certain specialties, and in particular, the national issue. The other risk we have is of further industrial action from our junior resident doctors and senior resident doctors.
Thank you, Kathy, and good to see that we are on a trajectory to having a very manageable vacancy amongst. Any questions? Kathy, we'll then take your research report, and then I'm going to suggest after that we'll go straight into the Cambridge Children's Hospital items. So, Kathy,
yes, so it's always nice to present the R&D report. Always very positive. The recruitment continues to be very strong. We've over 10 active studies, 63 of those are portfolio studies, and we have participants through all those studies. A really milestone for us has been the opening of the Peterborough Research Hub. So I was delighted to be involved in that along with the Mayor of Cambridgeshire Peterborough last week, the ribbon. And that is really going to ensure now that everybody who uses the trust services will have access, equal access to research, and that's really a huge step forward. Well done to the R&D team, their persistence. Our consent to contact policy, which has been in place for approximately 12 months, having a really visible impact. And the flip side to that is that the success is increasing demand on staff capacity. So that's the issue that we are looking at currently, how they might increase capacity. There is a very positive initiative to increase the involvement of non-medical staff in R&D. So there have been a number of part-time secondments offered to our AHP staff, whereby they get a day a week over a period of 12 months. And so we now have champions for R&D across the MDT and better representation. There are new targets that have been introduced by the government for set-up of interventional clinical trials. The metric is 150 days. And I'm pleased to say that our R&D team are on top of that. So they've streamlined and standardized their processes and implemented something called EDGE, which is a digital system to support portfolio management. The key risk to our strategic objective 3, which is to be a system leader in innovation research, includes estate restraints. So Windsor Research Unit is going to fairly soon not be adequate for the number of staff that we require to respond to growing demand, increased activity. There's also a gap in some disciplines, particularly psychology. There are discussions going on. So overall, I think the R&D is delivering a very strong performance and strategic value, and other clear plans in place to address the emerging pressures.
Thank you, Kathy. I think we'd all want to thank Ben and Rasha and the team, which is small but high impact, for the lead on research and development. It is astonishing how much is actually being undertaken. Holly, did you want to come in?
Just very briefly to talk Kathy about talking really about sort of medical-based research, but actually Ben and Nicola, our Director of Operational Performance, have had several meetings to think about some quite exciting sort of operationally based research that again will help us with our transformation and improving services for children. So I really welcome that in terms of that broadening the research perspective.
No, I have been delighted because I chair the research funding to see bids for small amounts of research money coming from the nursing area for the first time and from our AHPs and psychologists. So the more of that we can do, the better, because that will just make better health and better delivery.
I totally agree, and remembering the impact that has on our recruitment and justice.
Yeah, absolutely. Fantastic. Well, as I say, our thanks to Ben and Rasha, and we hope for a new home for them. He says, Marianne, I think slightly more Desres for the degree of research that is going on, I think. All right, I'm going to go to Isabel Heyman. Professor Isabel Heyman, you're very welcome, as is Professor Tamsin Ford, who's online, who are going to talk to us a little bit about the clinical model for Cambridge Children's. We talk a great deal about Children's Hospital for the East of England, which we are obviously key partners in delivering. We thought it was time to just bring to public board a little bit about the thoughts as to what is special about this, what the ambitions are for it. We've got about just over 20 minutes of time.
Check. I'm like a London bus. I turn up and I keep turning up. So I'm actually going to, as co-lead for mental health with Isabel, I'll just give the first presentation, but having Tamsin and Isabel here.
Right, fantastic. Well, all three of you will be a triumvirate of
my
glory.
apologies.
Yeah. Thank you.
Okay.
Over to you.
Thank you. So and there's going to be some very coordinated slide clicking because I have put animation in at one point. So can we have the first slide? I'm mostly going to use this slide to tell you what I'm not going to spend a lot of time talking about, which is that I just want to make the point about there being this is a long story and there's a lot of work both going on and that has gone on. I'll just very briefly mention what coming towards the full business case means, but the most important thing it means from our perspective as clinicians and sort of clinical leads is really trying to articulate the clinical model with the enthusiasm that I hope I'll be part of sharing. So if you could have the next slide. I think it was around 2015 that CPFT joined what was already a lengthy process of lots of bids to think about rehousing paediatrics at that point. And a formal joint bid first went in 2017. And I'm not going to go through the long process where we've got to, but we are a long way further on from there. So if we can just have the next slide. And again, just very briefly, the two areas that I'm particularly going to focus on in this kind of broad look at what the sort of work streams are the second and third from the right in the large boxes, transformation and transition. So the transformation is really around developing this notion of a future model of care. And over the last year and a half, we've developed a whole set of quite richly detailed what we call target operating models to really articulate in every part of the hospital how that might work and particularly how they might integrate. And transition obviously is becoming more real as we start to think, is this hospital is going to get built? Because it's about how we make sure that we create that transition from the status quo to this new model of operation. Let's move on rather than get bogged down in that. And very briefly, so the full business case, as I'm sure everyone here knows, it follows the successful strategic outline case, then the outline business case. The full business case is really getting government sign up to release funding. And it means, and if we just go to the next slide, what it means is for us to have made the full strategic case, the vision, the case for change, why is the status quo not okay, and what's the strategic context. And both of those really, again, require for us to have I didn't write the word visionary, but I think it is quite a visionary clinical model, actually. I think it is genuinely setting out to do something that is getting interest, not just around the region, but actually internationally, that we're going to try to do something that is quite new, this clinical model. So let's get to the meat of the talk, and if you go to the next. The whole new way, there's three quite important words in that. It is about wholeness. It is about bringing and integrating the many parts of what it means for a child's trajectory to go into adult life successfully. It is, as I've said, it is very new. And I like to remind people that it's a way rather than a single destination. You know, we talk a lot about integration and the integration of services. And I like to remind people integration is a verb, not a noun. It's not a state that you arrive at and there we've done it. It's an endlessly, needs to be reimagined and reinvented. So, but I think that the kind of critical things that I'd like to pick out here are this idea that the child is going to be treated in a much more holistic way. You know, mind and body will be treated in one place with the family and social context as kind of implicit in that. And rather than us having a siloed, disarticulated, I would describe it as disintegrated system of care. The care will wrap around the child and family according to need, which is a very big difference. We talk about the notion of the whole community, because this actually, in terms of, you know, remember the Eastern region is the only region that has no specialist children's hospital. And if we compare this in size to, say, your Alder Hayes, your Birmingham Children's, your Great Ormond Streets, actually it's a relatively small Children's Hospital. So its reach is going to be very different. It will be much more systemically engaged with services beyond its walls, really trying to be an active supporter of what I call intelligent interprofessional networks that reach right out into the Eastern region, so that specialist care will be not just closer to home for Cambridge kids, that's great, but actually will be closer to home for children and families across the whole of the Eastern region. And then this notion of a whole future, you know, there is and has been a valid argument of why would you bring a children's hospital to Cambridge, which already has so much? But that's why you have to put it here, because we have a research ecosystem here that is unparalleled. And to not place the regional children's hospital right in reach of that ecosystem would be such a waste of a potential. So to really kind of bring together researchers and clinicians in a way that I'll speak a little bit further about is part of the clinical vision. Research is not separate from clinical work. It is fully integrated. So the kind of whole picture of that is, you know, although we're building a building, actually what we're really trying to do is to create a very revolutionary change to the way that we think about children's care as a trajectory into adulthood that has to bring together, you know, the latest life sciences, bring together care, science, and genuine innovation. So I'll just whiz on and picture that in a slightly different way to the next slide. This is the one that has some animation, so we'll have to be perfectly in sync. I mean, everybody here will probably know that, you know, part of the work is to develop this joint endeavour where three very different and extraordinarily powerful organisations with a great deal of individually owned expertise are coming together to create a governance structure for a hospital. So if you press the clicker once, at the middle is this notion that, you know, integration is not just putting physical and mental health clinicians in the building together and saying, get on with it. There is going to have to be a very kind of major change in culture and training for the workers who work in this hospital. One of our target operating models, we call it the psychological and family approach. It really kind of will be a universal training for all staff to bring a kind of core shared understanding that's both trauma and neurodiverse informed, but that places the sort of family and, if you like, recognises the importance of the networks that these children exist in outside of the hospital at the centre of their wellness. So now we're going to get into the more interesting bit of animation at this point. So if you can just click once. Okay, if we imagine that the black circle in the middle is our patient, the current situation, if a young person is, for instance, in the Darwin Centre for Young People and Adolescents with significant mental health problems, but many of these, perhaps young people with eating disorders whose weight is at a level that they are physically extremely fragile. There may be all kinds of questions about kind of neurodevelopmental complications, autistic spectrum, the need for maybe some genetic testing. And they may also acutely self-injure themselves. Those all require different kinds of help. And if you could click the clicker now, this is what it looks like at the moment. They have to go on a right journey to these different people. And I mean, it's laughable because it's really expensive. Yeah. The people don't talk to each other as well as they should and could. And it's deeply disruptive to a young person who might struggle to make one relationship successfully. Asking them to make multiple relationships to people that talk, frankly, different languages, have different interests, is very different. So if we can click the clicker again and see how a hospital that would draw the right expertise around the bed so that the care needs remain the same. And if they need tube feeding, if they need electrolyte looking after, if they need wounds managing, if they need their mental health needs assessed, if they need genetic testing, they don't have to move. We move around them. And that's what good parenting looks like. And that's what good care for children in the 21st century should look like. So that's going to be supported by a whole raft of digital innovations. A single electronic patient record is not particularly innovative now, but we're working on making it better. Certainly AI is going to be a big part of that. Lots of exciting ideas about how you navigate and schedule these meetings, and a lot of work on the culture of how we help clinicians of different tribes to speak with each other and to keep learning from each other. Because what I have found is the level of excitement in clinicians actually is rising as this becomes a more real thing. Next click, if you could. The next one. Yeah, so part of the hospital will be this big research institute. And Tamsin and Isabel have a lot more useful to say, but I just want to talk about it as a very much coming from a clinical background with, I dabble in a bit of academic and treatment development work. But the point of this kind of, how do we tighten the loop between research, innovation, and then application and actual patient benefit? How do we tighten that from the years that happen at the moment to kind of something that could happen quickly? Having a research institute that not only is on site and will be engaged at a ward level and across all the professions, but that is also networked to, as I say, this huge research ecosystem that Cambridge is lucky enough to already have. That's a major difference for this hospital. And the next click. So this is just to remind people that, you know, this is a hospital that goes beyond its walls. It'll be a beautiful building. We've spent an awful lot of time in the last few weeks looking at the plugs and the sockets and the this and the that. But actually the important thing about this hospital is the porosity of those walls, that we will be reaching in and out. And I just highlight one or two things. The idea that, you know, we're going to be using, you know, virtual walls become something much more real than just the odd Zoom or Teams call of people. But this idea that the hospital becomes a hub of supporting and building the wider interprofessional network across both the locality and the whole region. And an exemplar that's already having a difference is this program Frontrunners. So we're really pulling out those clinicians that are frontline that know a small element of a service. And we're particularly encouraging them to come together with clinicians from other tribes or fields to find ways to improve pathways that only someone right at the front could really know what's needed. And we've run one cohort. We've got a second cohort just starting. And this, I think, is going to become one of the models, not just to sort of get the hospital in people's minds, but will probably become something that is one of the defining features of the hospital, that we keep working. And that notion that integrating is a verb. We need to keep knitting and weaving the services and the networks of knowledge and practice together. And that's the other element of that. And then click again. So I'm going to run, because I think I probably overstayed something. In the design, one of the things that's been very exciting is the architectural design of these, what we call universal rooms, that are unique. No one else has built rooms that are both suitable for children and young people with significant mental health needs, but that could also have all the gases and airs and suctions that you need for physical healthcare. That they are genuinely dual purpose and can be adapted for the needs of the child. Lots of rooms for families and parents and carers, so that they're not sort of add-ons, but they are absolutely part of the therapy. We've got a whole GAU that will, you know, really provide much higher spec accommodation than is currently the case in the Darwin. But that will effectively be that. And then we've got two other ward spaces where we've got a huge amount of flexibility to both kind of create smaller sort of pathways, but to work with young people with a much wider range. And to work particularly with people may have heard of this core 20+5. So it's one of the sort of inequity measures, the core most 20% most deprived of the population. the plus being whatever local inequities are noticed in a locality, and then the big five, which is diabetes, epilepsy, asthma, mental health, and dental health. And many of our paediatric colleagues, I now realise, really the patients that they get most terrified by is the patient with epilepsy whose epilepsy is so dangerously uncontrolled, not because they don't know what to prescribe, but because the mental health and the capacity of the family to create care around them is so also destroyed that they need that combined care. These wards could really manage these kinds of patients in a way that are absolutely unparalleled in anywhere else in the world, I would argue. So we've got this, I've talked about the psychological family approach. There's a huge emphasis on participation and work with service users, parents, and young people who have been, they really hold us to task. I write quite a lot of answers to people, but play and food are two of the kind of key big areas that are not little add-ons. They're central to how this hospital will be a hospitable place. And the school, the hospital school, this idea that the school is this small wedge of real life that helps the hospital not be a kind of bubble, but helps young people and helps clinicians, helps me to assess how a young person's functioning if I see how they're working in something that looks and functions like a real school. So there'll be a school in the centre and then rooms available for those young people who can't leave the ward. I've talked about deep system-wide integration. I'd really want to call out our intention to include our colleagues in social services. Clearly, you can make a great hospital, but if people get stuck there because there's inadequate accommodation afterwards. So we're involved in some very interesting and exciting conversations with our colleagues in Cambridgeshire Local Authority. Consistency of care, I think I've covered. And I suppose just for those who think, well, what would an integrated ward look like? It's not that we're going to just put all the patients in one great ward. There are what I would call kind of intelligent boundaries. Where we want flow, it will be possible. But where a young person's detained and needs to be contained, and where a young person requires dignity and privacy, the ward will be more than able through kind of a combination of kind of practices and architectural design to provide that. And it's, mental health for all. So a young person who breaks his or her leg will in this hospital get asked about the possibility that that ADHD impulsivity that meant that climbing on the carriage was a good idea might get asked about and might get treatment might get started right there and then, rather than waiting for another few years or more accidents or difficulties. So screening, assessment, and then sort of stepped evidence-based mental health care. Isabel and Tamsin will be able to say much more helpful things about the notion of how research will be integrated with treatment. But my experience of running teams and working with lots of teams around the world is if you can get a team to ask itself how we do what we do and why do we do it like that, and what would it be like if we did it better, that's the team that actually looks after their patients better too. So to me, research or clinical work without research isn't actually good clinical work. You breathe.
Well, I'm really aware of time. I was just going to say two things and then hand over to Tamsin just to say a few words about the Research Institute. I think it was so important that the physical health came up several times in the early discussions. I'm really glad I was here. And I think, Dickens mentioned that, but I think also we must think of the physical health care of our patients with severe mental ill health, which is often suboptimal. So not just substance misuse, but metabolic problems, obesity, increased rates of infection and other things. And to me, the term parity of esteem has been around for as long as I've been a psychiatrist, I think. But it's one of the reasons I'm so excited about this project is that I really think this is parity of esteem in practice. It cannot be pulled apart. If you're unwell enough to be in hospital, it doesn't matter if you've got a physical illness or a mental illness. Your level of need means that you're going to need to be in Cambridge Children's, and these children will be going to the same school, will be eating together on the ward. So to me, that's the most powerful way to break down stigma and to really have parity of esteem in practice, with obviously, as Dickon said, the constraints and boundaries that are needed if we've got an escapee or whatever else. And then the very last thing I wanted to say is that I know many of you are coming to our conference on Friday, which we're very excited about, and a lot of these things will be picked up and expanded on. We're really pleased we've got the Children's Commissioner, Dame Rachel D'Souza, coming, who I think Steve might have mentioned it, launched an important report this week saying that children are getting stuck in hospitals because you said nobody should be in for, somebody said probably one day more than they should be, but it's particularly that integration back into the community with other services, particularly social care. And so she's actually going to be formally speaking to that report for the first time at our conference, which I think is a really great bit of exposure. But we've got MPs coming, we've got lots of civil servants coming. Suddenly NHS England got very excited about all of it. So we're no pressure to put on a good day on Friday. But I'll hand over to Tamsin because I was speaking to the people at the Maudsley, South London Maudsley, who have also got a new building, which is integrating research and mental health. And they say this has caused such excitement because it's the first time these two have been put together. I said, yeah, but we're doing one better. We're putting together paediatrics and mental health and research. So do you want to just say a word about the CCRI?
Yes, very, very quickly in relation to time. I think it will benefit patients and clinicians and academics if we are all together. Firstly, really good applied research. The questions bubble up from clinical practice. And I know we do have clinical academics, and we have several in CPFT, Isabel and I being two of them, who relate to children, but it's not the same as that rubbing along day to day next to each other, the chance cup of coffee, sitting in a staff room together, those chance conversations when, you understand each other's problems. But equally, there is a gap in translation of up to 15 to 20 years across all kinds of research into practice. And again, that is easier if you have the relationships and the conversations, etc., and if the research is developed there. So I think this is enormously exciting and really important to really up our game to care for the children and young people of the East of England. And I won't say any more, but I'm very happy to answer questions.
I think I should say on behalf of yours, thank you so much. That's absolutely a brilliant presentation. So give that and I love the diagram. We'll probably be replicated for many areas of service, not just for children and young people, I suspect, unfortunately. And also to note that it's great that Rachel D'Souza is going on Friday. Rachel has shown a keen interest in this project for a while and has actually visited the site. So I think she is someone who is determined to be alongside because she sees what's happening as so important and lots of learning for children universally across the UK around putting them at the centre of everything and sort of abandoning this disconnect between mental health and physical health. We can do. But any questions at all for the wondrous three who've just spoken to us? Mike.
Hi. So I agree. I think they're fantastic. Okay. So a couple of thoughts. So this is not going to be built for another 5 years. So what we're doing now. So I could call out the front runners program. And given it's a hospital without walls, you don't need a hospital to do that sort of thing. So it seems to me vital that this concept is embedded now in advance of the building, which is going to facilitate the next step. You haven't mentioned, I'm a GP, so you haven't mentioned primary care, and I would argue that primary care offers integrated. I don't have a specialist, I'm a generalist, was, and so I think they will have something to say about this because you sit in your surgery with 2,000 patients registered to you and their family, and so I know you have, but I just wanted to call that out.
No, that's helpful. Actually, we should definitely have primary care on those
Yes.
diagrams.
I mean, having been involved in non-exec type roles, particularly at Addenbrooks, primary care does get forgotten. I don't know why, but it does.
My sister's a GP.
Yeah.
She reminds me constantly.
Right, well, we won't forget it. But anyway, thank you very much.
Rido.
Thanks, Precious. Just in, I think it's great to see some more detail there. I guess you made the point about talking to the region and reaching out and about primary care. I think part of this is to what extent the hospital will have capacity to provide perhaps more advice to community and regional providers than is traditional from hospital, where you send in your patient and then you wait for them to come out again. So it sounds like there's been quite a bit thought about extending the reach. I don't know whether that needs, for example, more staff than an average hospital might need, or whether
It's a really good point, Rudolph. So in the last 18 months, we've got a new regional development board, which meets with the broader region with representatives from everywhere. And it's besides those sorts of questions we've got on the agenda. We meet 4 times a year, but with some in between online. And I think the workforce planning around what it means to have better and more sustainable outreach without disconnects is really, really high on the agenda. I mean, one of the things we really think about is joint positions as well, where, it's been one of the anxieties of the region. Are we going to be poaching staff who want to, it is 5 years off? And I don't think we will be, because people want to work near where they live, but also people might want to spend a day a week, either in a more academic role or in a more specialist role, and go back, similar at all levels of care, actually. So a lot of those questions are very live, but I think we need to pin it down.
and those models about health specialists as well.
Exactly. And then, there's a lot of AI stuff, obviously, and digital, which, I think we need to have specific examples to pin it down to make it meaningful. But the virtual ward model, for example, for children with assisted ventilation, who are a very demanding group, that's really up and running already across the region. And intracranial pressure monitoring is something that's one of the front runners projects, remote monitoring, but coming back to the central paediatric neurosurgeons here, so there's things happening now, going back to Mike's point, that we can get going with already. So, but point well taken.
I'm going to bring in Steve, and then I'm going to have to move to those on this.
I'm going to be super brief. Thank you, Chair. Excellent presentation. Thank you. I mean, this is, it's not just groundbreaking. I think it's world first stuff, the way that we're talking about it. And maybe not the bricks and the mortar, maybe not the integrated model, but the actual ethos, I think that's definitely world first. And Dickon, there was a point that you made, I just want to draw out. There are a number of conversations that we have around the word prevention. And prevention of mental health is really difficult to focus on, because it's not the same as some of our physical care conditions where we see that. However, we do know early detection in things such as learning disabilities or people with progressive illness is something that saves lives and extends people's quality of life. So I don't think we should ever underestimate the power of picking things up early.
Yeah.
And that conversation that you just said there, that doesn't happen. And there's a whole variety of reasons why it doesn't. When it does, it's unusual. I think this is really powerful. And I think I'd urge us to think about this being a bit of a vanguard when we talk about prevention in terms of extended mental health access to services rather than stopping people becoming mentally ill.
It's such a good point. And when you talk about prevention in mental health, people always pick you up and say, give me an example.
Yeah.
And actually, that's very hard. But I think there's loads of examples of early detection and early intervention. So it's really important to highlight that.
Just to say that, the current population in the Derby, huge percentage of young people with previously undiagnosed autistic spectrum disorders, previous undiagnosed other neurodevelopmental vulnerabilities, that actually, in a different world, if those were picked up because they broken a leg, came in for appendicitis, that someone asked the question and that began a kind of chain, that could result in a huge difference. So,
And that's where the parity of esteem point comes in. It would be a a scandal if we didn't pick up somebody's blood sugar abnormalities and diabetes or somebody's asthma while they were in for another problem or whatever. But at the moment, mental health is falling below that bar.
Fantastic. Well, look, we're all very, very excited to see what happens in the next 5 years. I'm sure the things will continue to evolve, but it's going to be a fantastic facility. But I'm sure there's work we can do before the building is open to actually improve the experience of those we're caring for. So thank you, Dickon and Isabel and Tamsin, for the time you've given us today. It's been fantastic. I'm now going to ask the board to move to the last 3 items. One is very easy. I'm asking you to note the deal has not been used. Great. On terms of reference, we're asked here to adopt terms of reference for all of our committees, which have been through a high degree of scrutiny already. So unless anybody has discovered in their reading something that is not correct, I'm going to ask us.
I can take it offline, Chair. It's a consistency around quality. That's all.
All right, if you can agree with that, Martin, but that we'll note that being dealt with, we will approve them. Thank you. And Steve, we've got the modern slavery statement, which you referred to, and its importance. We are noting and adopting this. Everybody content with that? In which case, with my apologies that we're 4 minutes over, thank you to everybody online who has attended today. It's great to see so many of you. Some of our governors I will see next week, so I look very much forward to that. And thank you all, and thank you everybody here in the room. Have a good afternoon. Bye. Thank you.